Tawa again.
So, shall we start?
Yeah, it's beautiful.
Yeah. So good afternoon and good evening to all the respected teachers, delegates.
Sachin, kindly unmute yourself, Sachin.
Yes. So good morning, good afternoon, and good evening to all the respected teachers, friends, and all the participants of today's ACNS YNS webinar. We conduct this webinar on every second and fourth Sunday, especially for the education of young neurosurgeon. And today we have yet another interesting session, especially dedicated for the celebration of the Christmas and New Year, wherein we have two legendary guest speakers, Professor Takeshi Kawase and Professor Rokuya Tanikawa, and our YNS speaker, Professor Shunsuke Nakai. To chair this session, we have Professor Atul Goyal, who is Professor Emeritus at Department of Neurosurgery, King Edward Medical Hospital and St. G.S. Medical College, Parel, Mumbai, and R.N. Cooper Hospital. And he's a professor and head at Department of Neurosurgery of Lilavati Hospital and Bombay Hospital. Our chief patron, Professor Yokato, who is the president of ACNS. And the two discussants are Professor Alexander Wozniak, who is the chief of Neurosurgical Society of Ukraine, and Professor Abida Shah, who is the assistant professor in Department of Neurosurgery at St. G.S. Medical College and KEM Hospital, Mumbai. And to moderate today's particular session, we have Dr. Sneha Chitra, Dr. Ben NG, Dr. Liu, and Dr. Raja along with me. Before we start the webinar, may I request Professor Yoho Kato to say a few opening remarks. You have to unmute yourself, Professor.
So hello everyone. So even Christmas Day, I really appreciate the join and support the ACNS webinar. So today, Professor Kawase is my senior teacher's mentor, because Kawase Sensei is one of the best friends of Dr. Sano. Sano is my mentor, so I know him very well, and he taught us one of the anterior petrosal approach when I was very young. So I was very impressed at the time in another prefecture. And also, we are so happy to receive again of the Dr. Alexander from Ukraine, and also the Dr. Pawat from Afghanistan. So maybe in some of their countries, the YNS will join today's webinar. So we can learn many things from them. Thank you very much.
Thank you. Thank you very much, Professor Yokokato. So before we start, may I request the chairperson for today's session, Professor Atul Goyal, to say a few words about this particular session and about Professor Kawase and Professor Rokuya Tanikawa.
Yeah. No, it is my great honor and absolute pleasure to participate in this seminar. You have said that this seminar is an educational activity for young neurosurgeons. But I think today every neurosurgeon in the world will enjoy and learn. Dr. Kawase, there is no question, is one of the legends of skull-based surgery, one of the fathers of skull-based surgery. He started skull-based surgery very early in his life and in the life of skull-based surgery. He started with various approaches. One of them has become absolute famous and very popular. That is Kawase's approach. And this is not the only approach. He has developed and designed and popularized several approaches in skull-based surgery. He has done skull-based dissection, petrous bone dissections, and various things for several years. So there is no question in my mind that Professor Kawase is one of the fathers of skull-based surgery and one of the absolute great skull-based neurosurgeons. We also have one of the legends in vascular surgery, Professor Tanikawa, and I have no hesitation to say he is the master neurosurgeon. He has developed the techniques of bypass like nobody else in the world. He has promoted bypass surgery throughout the world. A good friend, younger to me, but absolute neurosurgeon. So we have a feast of skull base and vascular neurosurgery to be heard, to be seen, and to be emulated by everyone, young and old, senior, and every neurosurgeon. So, Sachin, be ready for this feast, and I'm sure we all will enjoy. And Professor Kawase, it is great honor and pleasure to see you on the screen today, Professor Kawase.
Thank you very much, Professor Atul Goyal, for those encouraging words. Professor Takeshi Kawase doesn't need any introduction, but just to complete the formality, he is honorary professor, School of Medicine at Keio University. He's honorary professor at Suzhou University, China, honorary president of WFNS, guest professor at University of Utah, at University of UCSF, and University of Cincinnati. And today he's going to talk about large sphenoid wing meningiomas, 7 technical steps for the safe removal. May I request Professor Kawase to share his screen and start his lecture, please?
Sure. Thank you for your introduction. First of all, Merry Christmas. It is my pleasure to talk at Christmas Day. So, may I talk first?
Yes, please, Professor.
Okay. Please present my slide again. This one.
Yes,
so today's my topic is large sphenoid wing meningiomas. Large meningiomas is completely different tumor, and the surgical technique is completely different from the small one. So I will talk about the 7 technical steps for safe removal, how to remove it safely. This is my series of 425 cases of skull-based meningiomas. And the sphenoid wing anterior crinoid meningiomas is up to 22%. So very major skull-based meningioma. And this is the concept of skull-based surgery. This slide was made in about 40 years ago by myself. That skull-based meningioma is like a very tough tree growing in the important space. And if you want to remove it superiorly, subdural approach, the important space may be retract. You have to retract the important space and may injure this one. And after removal, the root of the trees are still there, so it may cause a regrowth. However, if you access from below, the important space may be preserved, However, you have to reconstruct the base of the soil. So this is the same to the skull base surgery. So I will talk the 7 steps. The first step of surgery is craniotomy on the tumor base, not on the tumor dome. This is very important. This is one example. This is the middle fossa base tumor, so invading the base of the skull. So how to make a craniotomy? If you leave the base of the skull invaded by the tumor, this is one example of tumor regrowth of other case. So if you leave this skull base, the tumor may grow not only in the intracranial space, but also extracranial and also in the orbit. Very, very complicated case. You had to operate at the time of regrowth. So you have to remove the base of the skull invaded by the tumor. But my question to you, my question to audience, the pterional craniotomy, this is a very common craniotomy, or pterional craniotomy, is adequate for this case. Can you remove this base of the skull by this craniotomy? So my answer is no. The temporal craniotomy, more inferior craniotomy, with removal of zygomatic arch. Zygomatic osteotomy is very important to retract the temporal muscle inferiorly and resect, reach to the base of the skull. So this is very important. So this is the surgical photograph after removal of the base of the skull until the superior of the fissure, foramen rotundum, and the foramen ovale are opened. So you could find the trigeminal branches here, epidurally. So the tumor is still there, but very easy to remove it without any detraction of the brain. Tumor is covered by dura, so you can cut the dura and remove the tumor very easily without any detraction of the brain. And all the tumor in the skull, base of the skull, was gone. So the basal craniotomy is very important. Less retraction damage to the brain and possible to access to the feeding artery. And of course, you can remove the skull base invaded by the tumor. So do not make a craniotomy in the convexity side like this. If you create the craniotomy superiorly, you have to retract the brain so far, and it may cause the angry brain by over-retraction. So the craniotomy side is very important. So this is after removal of the tumor. So no degrowth from the basal invasion. And after reconstruction of the orbit. The cosmetically very nice. This is a second case of medial sphenoid wing meningioma originated from the anterior crinoid process. And from the anterior crinoid process, a lot of feeding artery originated. So how to access? So this is the angiography. And from where the feeding artery comes. This is feeding artery. It is called recurrent meningeal artery. It is a branch of ophthalmic artery. So embolization is impossible because this is an ophthalmic artery. But how to coagulate this feeding artery during operation? So this is the second step. So sphenoid, key point is sphenoid resection and epidural feeder control. This is a surgical technique. By removal of the pterional bone, epidural resection of sphenoid wing is made to open the superior orbital fissure. Sphenoid wing is resected until the superior orbital fissure is open. This is the superior orbital fissure, and it is covered with perios. So if you cut the perios one layer, you can find the recurrent meningeal artery there. And other small feeders between orbital fissure and foramen rotundum, you can find the lot of feeders, but it is running in the interdural space. So by cutting the periosteum alone, you can find and coagulate those feeders. And by extension of periosteal cutting medially, you can remove the anterior crinoidal process. It is very deeply located. So it becomes very easy to remove the process. I also present the movie. This is a left anterior crinoid process, and this is epidurally dissected. And medially, you can, this white one is superior orbital fissure and the perios. So perios is dissected, and this is recurrent meningeal artery coagulated. And after this, the anterior crinoid process is easily so drilled off. So once again, I'll show you once again. This is anterior crinoid process, and this white one is superior orbital fissure. And the perios is now cut, and the feeding artery, the recurrent meningeal artery is coagulated. And the periosteal cutting is extended medially, and this is anterior crinoid process, so easily resected. And this is the third case, 27 years old female. So this tumor also arising from the anterior crinoid process, and you can observe the feeders. So the patient had right clumsy hand, partial hand paralysis. And this tumor was removed without any injury to the surrounding brain. So the patient had clumsy hand disappeared after surgery, and she could write the letter. This is a fourth case. In this case, the meningioma encased the carotid artery completely. This is C3 portion, and this is C2 portion. So how to release this artery? How to release the carotid artery? The technique is the same. By resection of the sphenoid wing medially and remove the anterior crinoid process, you can access to the C3 portion epidurally. And during operation, this is the MCA, you can imagine the depth of carotid artery from C3 to M1, M2. So you can imagine the location of the carotid artery and depth of the carotid artery. And optic nerve was here, so optic canal was open. So optic nerve was frequently kinked by compression of the tumor. So it is freed from, by opening the optic canal, kinked optic nerve was freed from the tumor. So this technique is very important. This is on the way to remove the tumor on the carotid artery. And this is after complete removal. So if you do not remove the anterior cranial process, the tumor may not be removed completely. I removed the tumor with the dura. So the tumor was removed completely, including infiltration into the dura. So this is a total removal without injury to the brain and the carotid artery. So this is four advantages of epidural resection of the sphenoid wing. This is before resection of the sphenoid bone. The optic nerve was kinked, and the carotid artery cannot be seen, and a lot of feeders on the tumor. So by resection of the sphenoid wing, the kinked optic nerve was freed, and the depth of the carotid artery was emerging, and the feeder was controlled epidurally. And the brain itself, it was decompressed by resection of the bone. So this is a summary of four advantages: decrease brain retraction. Number two, epidural control of feeders. And number three, release kinked optic nerve. And number four, confirmation of proximal ICA. So this technique is very important for such a large meningioma. So I will talk about the third step of surgery. Third step is subdural feeder control. Because even by epidural control, total feeding artery could not be detached in some cases. This is one example of supernoparacellular meningioma attached on the lateral cameral sinus. So this is the cameral sinus here. So in such a case, feeders, from where feeders comes? This is the feeding artery originated from C4 portion. The name of the feeder is inferolateral trunk of the cameral sinus. So this originates from the cameral sinus, so epidural control is not possible. And from where it originates? It originates from the carotid artery and penetrated the tentorium to the tumor. So tentorium, penetrated tentorium, this is very important. So during operation, if you are looking for the tentorium, you can coagulate this feeding artery. By resection of the anticrinoid process, you may find the tentorium more easily, and you may find the inferolateral trunk here by small resection of the tumor. And after coagulation of IRT, no bleeding from the tumor. And you may find the very important structures, including PCOM, P1, and oculomotor nerve behind. So this is the technique. So this is the tentorium here. This is tumor. By small part of by removal of small part of the tumor, you can find this white bundle. This is IRT. You can coagulate this feeding artery during operation. And after that, tumor was removed. So such subdural feeder control is very important for such a tumor. And the complete detachment of feeders makes tumor soften and very easy to remove it. So I'll go to the fourth step of surgery. Fourth step is the dissection of arachnoid layer from the tumor. I'll talk about the anatomy of arachnoid on the tumor. Arachnoid layer is shown in dotted line, break line. This is arachnoid covering the tumor, and the pili artery are located in the subarachnoid space. And the feeders passing through the bone. And in some point, arachnoid layer is lost. by compression of the tumor. And on MRI, you can find the perifocal edema. So you can imagine the location of the break or of the arachnoid. And after craniotomy, what happens? After craniotomy, subarachnoid space is compressed by air pressure. Neurosurgeon sometimes does not know about this. By subarachnoid space is compressed by air pressure. So arachnoid, you can find a double layer of arachnoid on the tumor. So if you detach the arachnoid here, you can slip down the arachnoid. If you cut the arachnoid here, this pia artery will not come down. But if you cut here, the arachnoid maybe come down, and you can dissect the arachnoid layer very easily. So the pia artery themselves come down without any management. They come down freely by preservation of arachnoid. So do not cut the arachnoid here. So cut the arachnoid here. But if the arachnoid layer is lost, use surgicel for the no subarachnoid membrane here. This is a movie. Arachnoid is slipped down from the tumor. Arachnoid is not removed, but slipped down. So please preserve the arachnoid layer as far as possible. Arachnoid is slipped down, and the tumor itself must be removed without arachnoid layer. So tumor is suction. So arachnoid preservation is very important. And I'll go to fifth step. The fifth step is internal tumor decompression. After separation of the arachnoid, internal decompression is made. After feeder coagulation completely. So this is the technique how to make internal decompression. Before decompression, please confirm the important structures and please place the cottonoid between tumor and important structures. And after that, you must use the sonopet. So after confirmation of important structures like carotid artery and perforators, you have to place the cotton between tumor and important structures and remove it. Okay, this is a optic nerve A1 and M1. I'll go to the sixth step. This is a very important technique to remove the less marginal tumor margin. The tumor margin must retract away from the brain. So this is the technique. you have to retract that tumor margin away from the important structures. Retract the tumor toward the surgeon. Then no retraction damage to the brain. So if the tumor is very large, you can obtain enough space by retraction, and you can use sharp dissection. You can use a sharp tool. So retraction technique is very important. This is the movie. I always use the hooked tumor retractor invented by Professor Sugita. So without this tool, I can't remove the tumor. And by retraction away from the carotid artery, the tumor is removed gradually. And once again, the tumor is retracted away from the important structures and suction. Once again, the tumor is retracted away from the carotid artery or optic nerve. This is a oculomotor nerve. This is an oculomotor nerve, and this is a PCOM, and this is P1. And finally, I could observe the small vessels, important vessels, perforators. So this is after removal, all the tumor was gone. This is carotid artery. So do not retract the brain so far, but retract the tumor. Then no compression damage to the patient. This is a very huge tumor. Originated from the anticrinoid process. It looks very difficult, but no. Because please watch the space of the attachment. Attached point is not so wide. So it is like aneurysm surgery, giant aneurysm with narrow neck. So clipping may be not so difficult for the aneurysm. It is the same to the tumor. So attachment is narrow, even if the tumor is very huge, very easy to remove it by my technique. So if you retract the brain so far, very difficult to remove such a huge tumor. So her dementia, she had a dementia, but disappeared after surgery. So in the last, I will talk about when stop total removal. If the tumor invaded cavernous sinus. Recently, I do not remove the tumor totally. I left the tumor inside the tumor and treated by gamma knife. And another second one is adhesion to perforators or brainstem or to the brainstem. In such a case, I also do not dare to remove the tumor to spare the severe postoperative damage. Complication must be spared. This is a seven-step last step. It is foreclosure. Foreclosure use viable materials. because artificial dura and titanium plates are very expensive and not always safe. One example of biomaterial is pericranial flap. It is made at the time of craniotomy, not at the time of closure. I designed the pericranial flap anytime. And this is a combination with periost and temporal fascia. So it is very flexible, very easy to suture with the dural defect. So I always love this pericranial flap. And you must design the pericranial flap at the time of craniotomy, not at the time of closure. And this is how to reconstruct the small bone defect. I make a double layer of the bone using bone flap. Bone flap is separated in 2 layers. And the medial wall is used for reconstruction. This is no cost and safer. This is one example of orbital reconstruction using inner layer of the skull. So it is better than titanium plate. So this is cosmetically very nice. So this is my summary of 7 steps for large skull-based meningiomas. First step, basal craniotomy. And number 2, basal bone resection, including sphenoid ridge and anterior crinoid process. Number 3, feeder control and subdurally. And number 4, arachnoid dissection separated from the tumor and preserved. And number 5, internal tumor decompression. And number 6, remove the tumor margin away from the brain. So, and then number 7, reconstruction using vital tissues. And these 7 steps are applied not only for sphenoid wing meningioma, but all skull-based meningioma. For example, if the number 2, if the tumor invades the petrosal tip, I remove the petrosal tip, and feeder control is made by anteropetrosal approach. So these 7 steps can be applied not only for sphenoid, but for all skull-based. So thank you for your attention.
Thank you, Professor Kawase, for that wonderful lecture. This is a culmination of more than 40 or 50 years of doing extensive skull-based surgery, working with tumors, living with tumors, enjoying operating, knowing the complications, knowing the tricks, knowing the technique is absolute pearls of wisdom that we have seen today from Professor Kawase. As far as I know, meningioma surgery is experience. You have to do cases after cases after cases, and you have to learn by doing. You have to learn by dissecting. You have to learn by coagulating and getting hemostasis. You have to know when to stop, as Professor Kawase said, that if the tumor is stuck to the perforators, leave that part. If the tumor is going in the cavernous sinus and there is danger to cranial nerves, leave that part. You know, it is important to remove the tumor, but also important to know when not to remove the tumor. Absolutely wonderful lecture for all neurosurgeons of the world. And I will thank Professor Yoko Kato to giving this opportunity to all young and senior neurosurgeons to listen to this absolutely monumental work and great lecture from Professor Kawase. I'm very, very, very happy to hear this, Professor Kawase.
Thank you. I'm sorry, I have a earphone in both ears. Sharing is my problem. So if you, the attendants, have some question, please make the question shortly and clear. Thank you.
Atul Goel?
Yes.
Can I ask the very fundamental things, because I'm not used to the meningioma surgery, but I have a doubt. So can I ask Kawase Sensei?
Yes, yes.
A very simple question. Because if the tumor located just adjacent of the eloquent lesion, so your talk, the numbers 4 or 5, so the arachnoid membrane and also the tumor away from the brain itself. So it's sometimes quite difficult because it's very close to or very sometimes invade of the brain itself. So are there any tips? Just let us know, please.
Professor Kawase, can you give some tips?
In the case, the tumor is very soft. Yeah, it is a problem, but I will cover that tumor with cotton and retract the tumor.
Mm-hmm.
Thank you for your question.
Okay, thanks. Professor Kawase, another question from Dr. Alexander.
Professor Kawase, thank you very much. The great academic lecture. I also can recommend it for all the young and not young and sophisticated neurosurgeons. I have a question. First, about veins. Do you investigate the veins before surgery, and can it change anything in your approach in your surgery? The veins, it's one. And another question concerning the tumor which invades the cavernous sinus. How do you find the border in between the tumor you can resect and you must live inside of the cavernous sinus? Thank you. That's my two questions.
Thank you for your question. I'll answer from number 2. About so 1990s, I sometimes open the cavernous sinus and remove the tumor. But I could not spare the complication of double vision. It was very difficult for meningioma. The meningioma in the cavernous sinus was completely different from the subdural tumor. And the tumor easily attached to the carotid artery and cranial nerves. Very difficult to separate the tumor completely. So I do not like to open the cavernous sinus in the case of meningioma. In the noinoma, it is possible, but for meningioma, very difficult to remove the tumor totally inside the cavernous sinus. Thank you for your question. But I couldn't understand. I could not hear the first question.
Concerning the vein draining from the tumor and from the Sylvian fissure, the veins. Concerning the veins, veins outflow.
Yes. The tumor in the cerebral fissure.
No, veins.
I can find, get your question. Yeah.
Mhm.
I'm sorry, by my hearing disturbance, I can.
Okay.
I will
Okay.
I will suggest that we should write the questions and post
Okay.
it in the question box, and he can answer after Dr. Tanikawa's lecture. I think that may be a better option.
Okay. Thank you. Okay, that's fine. Okay.
Sachin, should we? Is there any other question from any of the participants or moderators or anybody?
But
Yeah, I can see Professor Ahmed raise
Professor.
the hand.
Ben?
I
Yeah, I
think
can
we'll
see
do what-
Professor Fassett raise up his hand.
Hello. Hello. Thank you.
Hello.
Konnichiwa. Thank you for brilliant lecture. It was really good. Excuse me, how to manage brain odem during the operation, and we are facing many times with brain odem, and then maybe a bit not good outcome after operation, and like to know your opinion about how to manage the brain edema during brain tumor operation.
Yeah.
I'm
Thank you.
Dr. Firzad from Afghanistan.
Thank you for your comment.
I think we'll do what.
Question in the chat box if you'd like to answer it now. From Dr. Burhani about steps in intraventricular meningioma. Would you like to share your expertise? In intraventricular meningiomas.
What kind of meningioma?
Intraventricular.
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 Yes.
Intraventricular meningioma? You mean?
Yes.
The technique is completely different. It is not the skull-based meningioma, but the intraventricular meningioma must be accessed by the interhemispheric approach. So, or depend on the location. So you have to open the brain. Yeah. So, intraventricular meningioma is completely different from the skull-based meningioma.
I think we'll do what Professor Ratul Goyal said. Let all of us who have the question, all of us write the question in the chat box. I would request Professor Kawase to see the question in the chat box so that it'll be easy for him. And we'll go ahead with our next talk. And after Professor's talk, then we'll come back to the question. I think that should be okay. Shall we do that?
Yes, Sachin, go ahead, please.
Yes. So may I request Dr. Sneha to kindly introduce next speaker, Dr. Gokuya Tanikawa, and his title of his talk. Dr. Sneha.
Thank you, Sachin. After that brilliant lecture from Professor Kawase, it's my honor to invite Professor Tanikawa, who is presently Executive Vice President and Director, Department of Neurosurgery and Stroke Center, Sapporo Teshinkai Hospital at Sapporo, Japan. Thank you, Professor, for accepting our invitation. Professor Tanikawa will be talking on microsurgical approach and safe treatment of intracranial aneurysms. Over to you, Professor.
Hello, can you hear me?
Yes.
Can you see my screen?
Yes.
Yes.
Okay. Thank you for your invitation, Professor Yoko Kato. And it's a great honor to see the Professor Kawase. I have learned skull-based surgery around for more than 20 years. And his principle is very important, as he mentioned, and I'm following his concept when I take out the tumor, not only skull base but also other parts, convexity somewhere. Thank you for your invitation, Professor Goel and Professor Alexander and Professor Ahmad. And thank you for your invitation, Professor Sachin. Everybody, I thank you to be here and to share my experience. My talk is about the vascular reconstructions and the microsurgical approach. The distal transluminal approach is a very popular approach for neurosurgeons, and this is a very important approach to approach any lesions, not only aneurysm but also tumors. But this is a distal basilar aneurysm, right side basilar supracerebral artery aneurysm. In this approach, I usually perform the distal transluminal approach to separate the fissures, to separate the frontal and temporal lobe completely. And with the highest magnification of microscope, you can confirm the arachnoid trabeculars and tiny structures like pyle vessels and Sylvian veins. Any vessels can be spared during approach with a meticulous high magnification approach. This is a separation of the anterotemporal approach adherent on the frontal lobe. This is the right side approach. Now, here is the separation between the frontal and temporal. And gradually, we can approach to a carotid cistern and exposing the internal carotid artery. Now here, you can see the MCA bifurcation. This is the right side M2 inferior portion. And I'm elevating inferior trunk of M2 from the inner surface of a temporal lobe. And the tiny anterotemporal artery is elevated from the temporal inner surface. And now, with the retraction of a temporal uncus, the arachnoid trabecular between the choroidal artery and the temporal uncus can be incised and separated. And here's a lyricus membrane lateral to oculomotor nerve. Here is so-called the oculomotor tentorial triangle. With this manipulation, the oculomotor nerve is detensed due to temporal retraction. Now, the medial lyricus membrane opening, the aneurysm could be exposed. Now, in oculomotor tentorial triangle, you can secure the basilar trunk as a proximal control. And with the highest magnification, you can see the clip blade is catching the aneurysm completely and not to bite the important perforator beside the aneurysm, just proximal of the right P1. And the remnant anterior part of aneurysm could be occluded by mini fenestrated clip. Here again, I'm confirming the perforators, and the ICZ video angiography shows a good filling of all the important vessels. The CT angio after the surgery shows no abnormal findings, and the patient recovered well. The basic approach is interhemiscal approach. I usually perform the anterior-in-time approach for ACOM aneurysm clipping. Especially this approach is very useful and a strong approach for a super projecting ACOM aneurysm. Of course, inferior projecting aneurysm, easy one, you can use the terminal approach, of course. But super projecting aneurysm like this, it is sometimes very difficult to confirm the posterior wall of the aneurysm and hypothalamic branches. Anyway, with the highest magnification, even in an anterior-in-time fissure, you can expose and confirm the tiny arachnoid trabeculae between bilateral sinus gyri. And again, with the highest magnification, the arachnoid trabecula could be incised and expose the whole M2 segment with this approach. Sometimes the tiny vessels is looping to the contralateral side from the belonging side. Anyway, now the double ball super projecting ACOM aneurysm is exposed, and the bilateral A1 could be secured. The left A1 is occluded with a temporal clip, and posterior aneurysm dome is occluded, and remaining part anterosuperiorly could be clipped by a second clip. And now, with the highest magnification, the hypothalamic branch could be confirmed, and I see the video angiography shows a good filling of the both A2 and hypothalamic branches. CT angio shows a good obliteration of aneurysm, and this is the illustration of what we did, drawn by my colleague Cosmo Noda. This is a very important approach to clip the ACOM aneurysm safely. I always emphasize that the clean operative field is necessary, especially a bloodless approach. So to do a bloodless approach and to achieve the bloodless operative field, we need a complete hemostasis, dissection of fissures, and after the micromanipulation, the dural closure should be performed watertightly, and if necessary, we try to do a microvascular anastomosis. Even in skull-based approach, the hemostasis is very important. This is the left side cholesteatoma patient, which invading into left petrosal bone. I am making the big frontotemporal craniotomy, maximize the craniotomy to the base, temporal base, and I am doing the orbital skeletonization and expose the meningo-orbital band to elevate the dura propria from the cavernous sinus wall. Now, the foramen rotundum supraorbital fissure is exposed, and now here is the foramen spinosum. The middle meningeal and the middle meningeal vein sinus is cauterized, and remaining the foramen spinosum is packed with bone wax. Here is a foramen ovale. The dura propria on the ovale is incised, and the V3 segment of trigeminal nerve is exposed, and the lateral loop is exposed here. And the foramen rotundum and the V2, V3 could be confirmed. Now, the dura propria is gradually elevated from the middle fossa, and I am confirming the breathing from the detached part of the skull base bone, And then now I'm confirming the greater superficial petrosal nerve. Lateral to the GSPN, I found a lesser petrosal nerve. Here, this is a hiatus of GSPN is coming in toward the geniculate ganglion. And this is a medial part to GSPN, along to a GSPN. And GSPN should be preserved, not to injure it. If the and now here, this is a medial part, medial to a GSPN, and gradually posterior margin of V3 is exposed. Now here, we can confirm the lesser petrosal and the GSPN. In between the lesser petrosal nerve and GSPN, there was a very thin bone, and we could confirm, we could expect there should be a C6 internal carotid right there. And this is a temporal rhomboid, including Professor Kawase's triangle. In this case, the cholesteatoma is invading in a petrosal bone from the middle ear, so this part should be drawn. Anyway, when we approach to a middle fossa, even in a middle fossa, the complete hemostasis is necessary to confirm the anatomical structures like this. Another option is microanasmosis if we injure something, injure the parent artery something. The first principle of vascular anasmosis is the everting of both vessel wall like this. The intimal layer should be attached to each other, otherwise you may have the acute occlusion after reflow of the apparent arteries. And the second principle is a Fishman streaming of the donor end when we perform the end-to-side anasmosis. At the donor end, the end should be cut up 60 degrees, and the other side vessel wall should be cut up. With this dimension, you can have the 2.3 times of diameter, and this is a shrunk diameter of the donor, and this makes the stitching length longer, but it makes stitching much more easier when we perform the end-to-side anasmosis. And this is a principle when we stitch the vessels, not only microvascular anasmosis, but also major vascular anasmosis. The stitching bite should be twice of the wall thickness, and the stitching interval should be 4 times the wall thickness. If you perform with this stitching manner, this can be called the square knot. With square knot, you don't have the blood leakage in between the stitching intervals. So this is an illustration when we perform the end-to-side anasmosis. The important thing is everting of both vessel wall like this. If you make the everting situation like this, and if you add the counter tension, counter force to the vessel wall, and from the other side, you can penetrate the both walls with one action. It makes temporal occlusion time shorter. And this is the side-to-side anasmosis. When we perform it, the bottom side stitching should be running suture from inside, outside, outside, inside. So in this stitch, you can realize that the bottom side two vessel walls cannot be inverted. It is the cutting edge of the vessel wall has a collagen fiber. Collagen fiber exposed inside lumen, and it may causes the thrombosis after reflow. So the principle is to avoid the acute thrombosis, we make the orifice bigger. And to do this, the arteriotomy should be more than 3 times of the parent artery diameter. And the arteriotomy should be curved symmetrically like this. Then you can make the orifice with the oval shape. I'll show you a retrograde suction decompression technique through the suprathyroid artery for difficult internal carotid artery aneurysm. This is the C2 segment ophthalmic aneurysm with a visual disturbance. Now the suprathyroid artery is cannulated with a 5 French infantile feeding tube. And after cannulation, the tip of a cannula is located in a common carotid. And the external carotid and the common carotid can be occluded when we need a proximal occlusion. And now, in this case, the STA M4 bypass is performed as a backup bypass when we have the accident of occlusion something. And now the Sylvian fissure is separated. Now the aneurysm is exposed. Still aneurysm has a tension. The temporal grip is placed proximal to PCOM distal to the aneurysm, and common carotid is occluded. Now the suprathyroid artery, the blood is sucked through the suprathyroid artery. Then the aneurysm could be decompressed, and the optic nerve decompressed like this, and you can make the space in proximal neck. Now, this is the distal drawing insides along the carotid. The superior distal drawing, which is connecting to a optic sheath, could be incised and decompress the optic nerve. Here, the distal and the proximal neck of the aneurysm is exposed, and this is a 762 large titanium clip is placed to occlude the neck. And now the common carotid and the distal occlusion is removed, and confirm the Doppler sound of a carotid. At this moment, I have doubt the aneurysm is still alive, and the aneurysm has a partial thrombosis like this. I am removing the thrombosis, and you can see the gradual arterial bleeding is coming from the inside aneurysm. This means that the aneurysm is not completely dead, because the medial part of aneurysm had a thin wall. So the fenestrated clip can occlude the medial thin part. This technique I learned from Professor Yoko Kato, Professor Sano's presentation almost 30 years ago. Anyway, with this technique, the retrograde suction decompression technique and the fenestrated clip, multiple clip technique, the aneurysm could be occluded and safely. The patient visual disturbance recovered well. I'll show you anterotemporal approach. This is a combined anterotemporal, subdural anterotemporal, and epidural cavernous dissection. When we elevate the dura propria from a cavernous sinus lateral wall, we can expose the cranial nerve, third, fourth, V1, V2 like this, and we can recognize the triangles in the cavernous sinus. These are very important landmark. Now, this is an example, 79-year-old female, basilar supracerebral artery aneurysm. This patient have the very tortuous hard atherosclerotic basilar trunk. So in this case, it is difficult to secure the proximal basilar just distal transcerebral anterior temporal approach. So in this case, we have already elevated the dura propria from a cavernous sinus wall by incising a supraorbital fissure. And additionally, the standard transcerebral approach, anterior temporal approach, is performed. And now the dura propria dissection is proceeded. And here is the foramen ovary, and this is the oculomotor nerve. The oculomotor foramen is open. Now, this is a cavernous sinus, the fourth nerve, and cavernous segment fourth nerve is being tried to free from the cavernous sinus connective tissue. The purpose of this dissection in a Parkinson triangle between the fourth nerve and the V1 is the basilar artery is very tortuous, and the internal carotid has a very hard atherosclerotic change and lay down laterally, and so the retrocarotid triangle is very narrow. So to extend the retrocarotid triangle, the dissection of the oculomotor foramen and the trochlear foramen and mobilize the oculomotor and trochlear nerve medially is necessary in this case. Now, the cavernous sinus, the connective tissue surrounding the oculomotor nerve is detached, and now the oculomotor nerve made free. Now here, the fourth nerve is adherent to a cavernous sinus connective tissue. Partially, the oculomotor cavernous sinus is opened, and I get the hemostasis with fibrin glue and gel form. And this is extended the Parkinson triangle. From this space, you can observe the basilar trunk, but still the space to place the temporal clip to a basilar trunk is narrow. So I'm opening the cavernous sinus. And in the depth, you could confirm the grooval triangle. I'm getting a hemostasis from the inferior petrosal sinus. And I'm incising dura toward the base side to extend the Parkinson triangle. And now, with this extended space of a Parkinson triangle, you can secure the basilar trunk lateral to a fourth nerve and third nerve. And now, here is the distal neck at aneurysm and P1. And as we expected, aneurysm is adherent to medial surface of the oculomotor nerve. The aneurysm must be detached from the oculomotor nerve, and you have to find the proximal neck between aneurysm and the supracerebral. Now, I'm trying to place the clip not to bind the important perforators just behind the aneurysm, because there is an important perforator just behind the aneurysm. You have to be careful not to occlude such perforators by clip tip. To confirm such a issue, we need the highest and the bright operative field, highest magnification and the bright operative field. And after neck clipping, ICG video angiography shows a good feeling of apparent arteries and the important perforators behind the aneurysm, supracerebral as well. And all the P1 and the contralateral P1 and all the perforators are spared well. Now, this is a dural closure from the base, and the meningoopter band is reconstructed, and the watertight closure is done. And the CT angel shows a complete neck clipping, and in this case as well, no oculomotor, no torcular pause happened immediately after surgery. And what we did in this surgery, this is a very special extended approach. The extended Parkinson triangle by mobilizing the trochlear foramen, the oculomotor foramen, and confirm the groovus ligament and confirm the abducens nerve as well, which is coming up through the dural canal through the inferior petrosal sinus. This is a very important anatomy when before we try to do this approach, we need a cadaver dissection and practice. I'll show you an example of the STMCA bypass reconstruction for thrombosed giant middle cerebral artery aneurysm. This is actually a MCA bifurcation aneurysm originally, but by the enlargement and the thrombosis, it looks difficult. But with revascularization to distal MCA territory with the both branches of superficial temporal artery, now the aneurysm is exposed in a distal transribin approach, and the inferior trunk and the superior trunk is exposed beside the aneurysm. And the one of branch of superficial temporal artery is anastomosed to frontal M4, and another branch is anastomosed to the inferior part of the M2. Anyway, after revascularization, the aneurysmectomy and thrombectomy is performed, and the almost thrombus is removed, and the reddish part can be sucked, and then you can have the bleeding from the orifice of the aneurysm. Unfortunately, this aneurysm neck had the calcification, and it was impossible to do a neck clipping. So I decided to remove the aneurysm completely, and I'm confirming the superior trunk of M2 is revascularized by a STMC bypass, and here the M1 distal and inferior trunk of M2 could be stitched, could be connected directly with the end-to-end anastomosis. In this stitching, I usually use the Pronova suture. This is a 8-0 Pronova. Here is a stitch at 5 o'clock. Then from the 5 o'clock toward the 12 o'clock, you can stitch up. Now the other side could be finished, and end-to-end anastomosis is confirmed. and the remaining of the aneurysm dome could be resected. The ICG video angiography shows a good filling of the bypass and end-to-end anastomosis at M1 and M2. Diffusion image immediately after surgery shows no high signal area in MCA territory, as well as in perforating artery territory. So, in summary, the recommendation in the cerebral vascular surgery is a clean and bright operative field, hemostasis in every step. The highest magnification of microscope for exact dissection is necessary. We can cut the only arachnoid membrane. All veins should be preserved. This cerebral separation is a basis of microsurgery, especially for microanastomosis. With this technique, we can achieve the skill to perform the exact microanastomosis, as well as the watertight dural closure is very important when in end stage of the surgery. Okay, almost time to finish. Thank you for your attention. Thank you very much.
Yeah, Dr. Tanikawa, that was a very, very fantastic presentation. See, Dr. Tanikawa has been one of the foremost leaders of intracranial bypass surgery, one of the leaders, one of the very early proponents of bypass surgery, and he has taught bypass surgery in various kinds of indications, particularly for, as we have seen, for aneurysm surgery. Of course, there is development of endovascular surgery and there is development of microneurosurgery, but what we have seen is the development and the peak of bypass surgery. And this bypass surgery is now being taken over by various neurosurgeons all over the world, and it is very important for all young neurosurgeons to learn bypass. And there is no way you can say, I don't want to learn bypass surgery. And to have the skill of taking sutures, skill of doing anastomosis in the depth, and in a situation where there are critical neural and vascular structures all over the place, it is very important to know the technique and have the skill of bypass. And here what we have seen is not only bypass and vascular surgery, but also skull-base surgery, to go into the cavernous sinus, go into the, cut the Gruber ligament, get to the sixth nerve, get to the third nerve. So it is the height of skull base and height of vascular neurosurgery that we have seen from Professor Tanikawa. And we have to know the indications. I am wondering, Dr. Tanikawa, I want to just ask you a question. You know, you showed a very complex aneurysm in a 79-year-old lady, which was unruptured aneurysm. So what is your current indication and philosophy about unruptured aneurysms in general, and in a situation of age which is such elderly, you know, no matter what, there are risks of surgery, there are complexities of surgery. You can have, you know, when you do bypass or aneurysm clipping, you may have to have temporary control. So all these things considered, what are your current indications of treatment in particularly in elderly and particularly complex aneurysms and particularly unruptured aneurysm? I would like to learn from you, Dr. Tanikawa.
Thank you very much. Thank you for your questions. Yeah, of course, the case I showed you, such the elderly patient, I always avoid the direct surgery first. I recommend observation as for such a patient in my outpatient clinic. But the problem is even such a patient have the so strong anxiety of the rupture, And even around 80 years old patient strongly requires the direct surgery because many of endovascular surgeons do not want to coil such a complex one. And so we need a very long time to discuss the surgical indication with the patient and the patient family. Longest one, I spent 5 years to operate the direct surgery. So basically, I don't perform the direct surgery for such an elderly patient, but it depends on the patient and the patient family's hope. So if they want strongly, I have to make the informed consent, especially about the complications, especially in perforating artery territory ischemia, because as we saw, such a patient always have the strong atherosclerotic change. Just the temporal occlusion may causes something ischemia. So that's so dangerous. So basically, the high age, more than 70-year-old patient is not a surgical indication personally, but depends on their hope.
Thank you, Dr. Tanikawa. You know, to have the confidence, I will say to have the confidence to do such a surgery in such an age group of the person is not easy to get. You know, you have to do more and more cases. You have to know when the person can get complication, when you should not do, when you are able to do. After all, you know, when we are operating, we have to look in the interest of the patient. So I think it depends on your personal experience, personal confidence, and techniques, of course, are absolute. So any other questions from the panelists and from any other moderator or anybody? It will be interesting to hear what the panel feels about it.
Before we go for the question, I would request Professor Alexander and then Professor Abhidasha to make comments about Professor Rokuya Tanikawa's presentation. Professor Alexander first.
Yes. Professor Tanikawa, thank you very much. The great presentation, great videos as usual. I'm really fascinated with your surgical techniques for many years already. So I follow you since the time you visited Helsinki. It was many years ago. And then I follow your publications for your presentation. Thank you very much. I can see your big progress every time from good techniques. You go to the conceptual things. You analyze your material and you to perform, and you're developing a conception of neurovascular surgery. So thank you very much for this. And a question for you: how many dissection courses did you attend during your lifetime?
How many what?
Dissection courses, hands-on dissection. It's for younger students.
Skull-based.
Skull-based dissection, yes.
Yeah, cadaver dissection is important. Maybe more than 30 times of skull-based course. Actually, I began to run the skull-based in 2000 when I was 38. At the time, the Professor Fukushima often held the skull-based course in Florida. So I participated that course twice in a year. And So maybe around more than 50 heads, I dissected meticulously, usually for 3 days course.
Okay, thank you, thank you. I know it. It's information for our younger colleagues, and it illustrates that only hard work could be a base for good progress in neurosurgery. And thank you very much. Thank you.
Thank you.
Mr.
Dr.
Tanikawa,
Abhidasha?
yeah, Professor Tanikawa, that was a fantastic presentation and very good, wonderful, elegant technique. I have one question for you. Would you suggest endovascular treatment directly for if you had to select endovascular treatment, which aneurysm would you select for endovascular?
Yeah, good question. Actually, we have a few cases of endovascular coiling in unruptured and ruptured aneurysm. The recent endovascular case was basilar ICA ruptured aneurysm. That was so-called the sidewall type aneurysm. So, and the ICA bifurcation aneurysm. So it's the direct approach is possible or not? It's possible, but too invasive in acute subarachnoid hemorrhage. So we chose the endovascular coiling. In that case, without stenting, because of the ruptured aneurysm, just a simple coiling, and it worked well, and the patient recovered. And in unruptured aneurysm, we choose the endovascular for paracrinoid, especially the suprahypophyseal aneurysm or carotid cave, which is the medial projecting C3 aneurysm. These aneurysm, we used to do a neck clipping directly with the anticrinoidectomy, but we stopped to clip the aneurysm now because we have a very high incidence of the visual disturbance after the surgery, because interestingly, immediately after surgery, patient visual acuity is good, perfect, but more than 36 hours to 84 hours, patient gradually have the visual disturbance and visual loss, become a blindness. So we have a big discussion of what was wrong, what is the mechanism of the delayed visual disturbance, but still we don't have the clear answer still. Now, so we stop the neck clipping to such a paracrinoid medial project suprahypophyseal aneurysm. And simple coiling to that aneurysm is excellent. Usually nothing happens. So if the unruptured aneurysm and the aneurysm is a relatively large one, we can indicate the choice of endovascular treatment for the patient. But basically, we do observation. We do observation first.
Thank you, Professor Tanikawa.
Yeah. Thank you.
Thank you, Professor Tanikawa and Dr. Abhidasha. You can see Dr. Kawase has a hand raised. Dr. Kawase Sensei, you have to unmute yourself.
Dr. Tanikawa, in my generation of 30 or 40 years ago, the transcavernous sinus approach for posterior fossa aneurysm was very, very active. But gradually it was replaced by endovascular technique. So do you think this approach is still have some indication for the posterior fossa aneurysm? Do you think so?
Yeah, that approach is very limited, very special. Usually, it cannot be applied generally. So it should be limited. And now nowadays, the distal basilar aneurysm treated by endovascular treatment, and they have the very good result. But especially in our institute, the patient who referred from other hospital to our institute often refuse to treat by endovascular surgeon. So we have no choice to do a direct surgery. So when we try to do a direct surgery for such a difficult aneurysm, the most important thing is the how to safely secure the basilar tongue. In such case, extending the inferior surgical field by dissecting the such a oculomotor or fourth nerve mobilization may be useful in a very limited case. But I do not recommend this approach in every case, of course. And this requires many experience and many practice in a cadaver dissection. So very, very limited, a very limited surgical indication.
Thank you.
Thank you very much.
Thank you, Professor. So if anybody has any question from the attendees list, just raise your hand and I'll promote you to panelist and you can ask question or you can type your question in the question answer box. So I can see one hand raised, Dr. Bakhtiar Burhani. Dr. Bakhtiar, please introduce yourself and ask your question, Dr. Bakhtiar.
Thank you very much. I'm Bakhtiar Burhani, a neurosurgeon in the Netherlands. I come originally from Afghanistan. Thank you very much, Dr. Tanikaya. Very nice lecture. Especially, I love the movement of arachnoid cutting with the curved scissor, what you did. It's nice work. About clipping of aneurysm, what is your thoughts about temporary clipping? Because by echoaneurysma, I think that was elective surgery. And there was no rupture. You temporarily put the clip, and especially in this case with atherosclerotic arteries. What is your thoughts about? Is it also possible to not to do that? Thank you.
Thank you for your question. That's a good question. Basically, I do not press a temporary clip on the atherosclerotic part. I avoid to press the temporary clip on a plaque part. We have to find the no atherosclerotic part when we try to do a temporary clip. If there is a very atherosclerotic parent artery, I often not to use the temporary clip when we perform the aneurysm clipping very carefully in unruptured aneurysm. So basically, we have to avoid such an atherosclerotic part.
Thank you very much.
Yeah.
Thank you. Thank you very much, Dr. Bakhtiar Burhani, for actively participating. Dr. Ben, please go ahead.
So, hello, Professor Tanika. Thank you so much.
Hi.
I'm Ben from Hong Kong, one of the young neurosurgeons. So, thank you so much for sharing in this Christmas day, and Merry Christmas. So, it's a very wonderful lecture. So, my question is that sometimes when we handle some difficult aneurysm, so for example, some calcified aneurysm or some aneurysm that's previously coiled, so the aneurysm sometimes fail to coast completely. So in this kind of situation, so
Uh,
what is your approach to this situation?
You mean the recurrent aneurysm?
Yeah, sometimes the aneurysm have a very tough calcified wall, or there may be some aneurysm that's previously coiled and then get recurrence. So when you put the kip fail to close completely. So do you have any experience on that, and what is your tips for this?
I have many experience after the previously coiled aneurysm or thrombosed calcified aneurysm, as I showed you today. Basically, if the aneurysm has a thrombosed giant coiled aneurysm, without removing coils, you can't occlude the aneurysm completely. And so in such case, absolutely, we need a vascular reconstruction distal to the aneurysm, like a STA, M2, double barrel bypass, something. And securing blood flow to a distal territory, to the aneurysm, then we can trap the aneurysm completely, usually 3-point occlusion of parent artery. And then inside the aneurysm, we should do an aneurysmectomy and the coil removal, and then completely remove the coils from the aneurysm neck and remove the aneurysm completely. Then if the neck was intact to be durable after neck clipping, you can try to do a neck clip. But regardless, thrombosed coiled aneurysm or the naturally thrombosed giant aneurysm, usually the intimal layer beside aneurysm orifice is not normal. Usually, the intimal endothelium has a damage. So if the neck clipping could be performed during surgery, we need to observe whether the parent artery is not occluded or not during surgery, at least 1 hour after neck clipping. So the thrombosis after neck clipping often happen. This is the reason why I performed the vascular reconstruction to distal territory beforehand.
Thank you so much.
Yep.
Thank you. Thank you very much, Dr. Ben. So are there any other questions from anybody? So if not, before we go ahead for the next session, I'll ask one question each to Professor Tanikawa and Professor Kawase. First, Professor Tanikawa. Professor, when you're doing vascular anastomosis end to side, especially on the surface of the brain, it's very easy because you have a lot of field and sometimes you can flip the current vessel a little bit. But the last case which you showed, wherein you do end-to-end anastomosis, but deep down the sylvian fissure, it's very difficult, especially when you put the sutures on the opposite wall. So for the young neurosurgeon, some tips how to do that. Could you please give some tips?
Yeah, it's a good question. Many neurosurgeons asks same question. That stitching technique, many of neurosurgeon focuses the technique to stitch, but the technique of stitching is not important. The important thing is to make the operative field, the operative environment comfortable for you. This means that you need a wide separation of a sylvian fissure from a distal. The meaning of a distal is the exposed M3, M2 segment in intra-cistern. And the whole M2 segment must be exposed. And M2 segment, whole segment of M2, MC bifurcation, and M1 completely separated frontal and temporal lobe toward the distal carotid artery. with this condition, the even MCA bifurcation of M1 segment is easy to stitch. So the concept of this meaning is the separate the Sylvian fissure as wide as possible from distal to carotid system. And prior this manipulation, as Professor Kawase mentioned, we need a skull-based concept. In a frontotemporal craniotomy, this is one of skull-based craniotomy because the sufficient sphenoid-rich removal until the meningo-orbital band is exposing the orbital roof, orbital skeletonization. If orbital skeletonization is performed, the base side to the Sylvian fissure is widely opened, and you can have the wide operative field after separating Sylvian fissure distally. So this is a key. The stitching technique is not so important thing. How to make the environment is most important.
Thank you very much, Professor. And Professor Kawase Sensei, just one question. With your lifetime experience, if you want to give some do's and don'ts for the young neurosurgeon, what are the tips you want to suggest? We want to hear it from you, Professor. You are muted. Kawase Sensei. Professor Kawase. You are muted, Professor. You have to unmute yourself. You are muted. We can't hear you. No. You have to unmute yourself. We can't hear you.
Kawase 先生、声が聞こえません。
Okay.
Yes, we can hear you now. Yes.
I can't understand your question. Once again,
my question is, with your lifetime experience, if you want to give some tips for the young neurosurgeon, some do's and don'ts, some tips you can give for the young neurosurgeon, please, Professor.
For the young neurosurgeon, my comment to young neurosurgeon.
Yes.
So the skull-based technique is that is the reason how to protect the brain. Yeah? So please understand and use that technique not only for the tumor but for the cerebrovascular disease. That skull-based technique is was made for the objective how to protect the brain. Not for the tumor, not for the remove the tumor totally, not always, but how to keep the brain intact. So that concept is more important. Thank you.
Thank you very much, Professor. Indeed, that is very important. If there are no other questions, then we'll move ahead with our next and the last speaker. I'm so sorry, Professor Shunsuke Nakai, that I kept you waiting for so long. So let me quickly introduce Professor Shunsuke Nakai. Is the Senior Assistant Professor of Department of Neurosurgery at Fujita Health University. And he's going to talk about surgical approaches to the inferior horn and resection of the tumor located in the mesial temporal lobe using some awake craniotomy strategies. So over to you, Professor. Please kindly start your presentation.
Can you see my slide?
Yes, we can see it, Professor.
Thank you. Thank you very much for introduction, and I also want to say thank you for all professors for giving me opportunity to talk. It's a great honor for me to do presentation in such a wonderful seminar. My name is Shunsuke Nakae. I belong to Fujita Health University Department of Neurosurgery. In our university, I'm doing glioma surgery, epilepsy surgery, and wake surgery using several kinds of neuromonitoring. So today, I'm going to talk about surgical approaches to the inferior horn and resection of tumors located in or near major temporal lobe. I think it is very important to identify the inferior horn when we detect tumors located in the major temporal areas. Once the inferior horn is detected, we can understand the anatomical relationship around there. It is also very important to understand how we can get to the inferior horn. In addition, tumors located in this area, for example, hippocampal tumor, sometimes cause intractable epilepsy. In such case, epilepsy control is also important as well as tumor control. Today, I'm going to talk about therapeutic strategies for tumor located in this area. This slide shows strategies for tumor located in this area. First of all, we examine whether or not patients have epilepsy based on the medical interview and the EEG. And next, neurophysiological tests are listed here are performed to mainly examine memory functions. And then we decided the surgical strategies based on these tests. Here, I show the possible surgical approaches to the inferior horn. First, a transcerebral and transventricular approach is upper root, and transcortical approach is lateral root, and subtemporal approach is lower root, and transplanum polar approach is anterior root. And finally, SCTT is a posterior root to the inferior horn. But usually, these surgical routes are not enough wide for tumor resections. So in many cases, we select ATL for tumor located in this area. Surgical procedures of ATL is first, temporal tip is resected to create enough surgical windows. Then, inferior horn was detected, and next a hippocampus is detected. And normal structure around there in the major temporal lobe, including choroid plexus and fimbriae, are confirmed. Then a tumor is resected based on these structures. We decide quadrigeminal system level is posterior limitation of resection in the ATL. Usually, ATL is selected in cases of intractable major temporal lobe epilepsy. In epilepsy surgery, normal structure such as the inferior choroidal point and anterior choroidal artery and choroidal plexus are usually intact. So we can detect these structures and consequently figure out anatomical relationships around there. Moreover, hippocampus usually atrophies. So these pictures are cases of selective amygdala hippocampectomy for hippocampal sclerosis. In this case, I selected transcerebral and transventricular approach to resect hippocampus, and the hippocampus was selectively removed in such a small window. But in the case of tumor, sometimes we cannot find this normal structure, especially choroid plexus. And usually hippocampus is sometimes very, very enlarged, like this picture. And pia mater is sometimes damaged because of tumor growth. So we need to be very careful because anatomical anatomies may lead, abnormal anatomies may lead disorientation during surgery, and superior resection of tumor may not be safe if pia mater is damaged by tumor growth. This table showed case series of tumor located in this area since August 2019, when I was back to Fujita Health University. These cases are right side cases, and these cases are left side cases. In most cases, we selected ATL or transportable approaches because we need wide surgical windows. In dominant cases, we sometimes resected tumor in awake surgery. I'll show some representative cases. The first case is a 60 years old right-handed female, and she underwent generalized tonic-clonic seizures. Unfortunately, she has claustrophobia, and she cannot be taken MRI without sedation. She was examined by HCT, and CT image did not show any lesions which could be a focus of seizures at that time. And 6 years after the first seizure, HCT was taken because of head trauma, and a very large hippocampal tumor was detected. Actually, her family noticed her behavior arrest without consciousness lasting less than 1 minute, but none of her family members recognized the symptom as seizure symptom. In the ictal EEG showed very frequently sharp wave in anterior and middle temporal. Her memory function, especially verbal memory and detailed recall, was extraordinarily decreased. And this is preoperative MRI, and the origin of tumor thought to be hippocampus or hippocampal gyrus. And very, very, very enlarged, and ankle herniation already occurred. In this case, it is almost impossible to reject, growth total rejection is impossible. So I selected ATL in this case. When we rejected hippocampus, the patient is usually placed in the supine position, like this picture. The head was fixed in a strong buttocks down position. So I think the awake surgery is not encouraged when tumor extended to posterior part of the hippocampus because of this strong position and the long surgical time. So here I'll show the movie, and this is a temporal lobe and the frontal lobe. First, I separated Sylvian fissure, and if the cortex was exposed, because I would like to know the position of M2, and then separated the frontal lobe and the temporal lobe until ICA and optic nerve was detected. And then I started temporal lobe resection about 35 millimeter from the tip. This is a major area of temporal, and I found the inferior horn here, and this is the hippocampus. The hippocampus was very enlarged, and this is the innominate circus here, and I detected midbrain and PCA. I was looking for the choroid plexus. It should have been there, but I couldn't find. I was still looking for the choroid plexus, but not here. And this is a PCA, and I received 2 more around PCA. And this is, I cut the illuminate sulcus to tentorium. I always check the direction of midbrain, and this direction shows posterior limitation is very close. So I stopped resection 2 more, and I confirmed the bleeding stopped and surgical was finished. In this case, the left hippocampus was very, very enlarged. The normal structure of major hippocampus, such as the choroid plexus and fimbriae, could not be detected. The pia mater of major temporal lobe was damaged. In such situations, if you see innominate sulcus, we are not sure whether or not this sulcus was actually innominate sulcus. But if you cut the innominate sulcus downward, you will definitely reach to the tentorium temporal base. So I think this is a good landmark how to confirm the innominate sulcus during surgery. And this is a post-operative MRI, and the histology of tumor was diffuse astrocytoma, IDH wild type. She had choroidal after surgery, and she has not had any post-operative therapies after surgery, but no tumor recurrence, and seizure-free more than 3 years. In a different case, a normal anatomical structure was not identified during surgery like a previous case. In this case, a historical picture showed atrophied choroid plexus, which was too small to be recognized by a microscope. It suggests choroid plexus was degenerated because compression of tumor. In our case series, choroid plexus was identified only 4 cases out of 9 cases. On the other hand, the innominate sulcus was detected in all cases. So I think the innominate sulcus is very important to detect. There are few reports which shows how to reject panhippocampal tumor. In the previous study, they also encouraged 2-stage surgery. Transsylvian and transventricular approach is performed fast, and then SCTT is performed. I think it can be a good option for panhippocampal tumor if it is not so large. In the SCTT approach, we can directly reach major temporal lobe structure, such as fusiform gyrus and parahippocampal gyrus or ringer gyrus, after we cut the tentorium. This approach is sometimes compared to subtemporal approach. In subtemporal approach, we need to strongly pull a temporal lobe, which may occasionally result in contusion or venous infarction. Such complication can be associated with severe neurological deficit, especially in the dominant side. According to the previous study, the surgical field in the subtemporal approach is deeper than that in SCTT. So when we want to approach to the posterior and major temporal lobe, I think SCTT can be a good option. Next, I am going to talk about visual field defects in this surgery. As you know, visual field defects are frequently seen in patients who underwent the ATL, but it seems there are individual differences whether or not the patients have visual field defect after surgery. For example, in this case, we approach the tumor in this direction because I wanted to avoid visual field loss. But in this case, I approached more laterally, comparing with this case. But visual field loss occurred in this case and not in this case. So I think it seems difficult to operatively evaluate whether or not the visual field loss is occurred after surgery. So here, I show the fibers related to the visual field. Fibers associated with visual field is from lateral geniculate body, and then it runs forward along upper wall of inferior horn, and it turns the direction and run backward along lateral wall of inferior horn. If we want to avoid visual field loss certainly, we select transpronal approach that is the anterior route to reach the inferior horn. We select this approach in cases in which tumors are located in ankles or hippocampal head. The transpronal is here, located here. This is inside rhinal sulcus. Usually rhinal sulcus runs here, and M1 early temporal branch runs on surface of rhinal sulcus. So it is deeper than Riemann inflow, which is a level of MCA bifurcation. In this picture, this approach directs in this angle. So we can certainly avoid optic radiation, which runs like this. This is a case presentation of 60 right-handed male patient. The tumor was incidentally detected in right ankles and hippocampal head. After the detection of tumor, he experienced the first seizure with impaired consciousness that started with nausea. An antiepileptic drug was started, but seizure control was not enough. And finally, he selected the tumor resection. Because tumor is located in anterior part of major temporal lobe, we selected this approach for tumor resection. I will show the movie. And this is the right case, so this is the frontal lobe and the temporal lobe. So first, I separated Sylvian fissure. And you can see cyst here, so this is a tumor. This is a tumor, but this is, here is pronoun polari. So I rejected tumor not to go outside pier because there are a lot of important structures in this system. So I found inferior horn here. So this is the anterior root. You can see amygdala, ankles, and hippocampus linked like this. Then I detected tumor along hippocampus, not to go outside pier. And because I wanted to stop seizures, I added hippocampal transaction. This is the final view of surgery. This is a post-operative images, and the tumor was totally removed. Histology of the tumor was DNT, so he has not had any post-operative therapies after surgery. His visual field was not detected. Defective seizure were not seen after surgery. Finally, I am going to talk about memory function. This table shows the result of WMS R-squared, which stands for Wechsler Memory Scale Revised. The upper shows right cases and the lower indicates left cases, and extraordinarily lower values were highlighted in green. Accordingly, cases in left side tend to show lower scores, especially verbal memory and delayed recall. Although this is a small population, this table shows the average of age and memory function in your case series. Accordingly, the average of right and left, average age of right and left cases are almost same, but some memory functions, for example, verbal memory and total memory and delayed recall, were decreased in only left cases. Hopefully, we want to know long-term effects on memory function by detecting tumor located in this area. But I think there are several factors that can be associated with postoperative memory functions. For example, seizure prognosis or extent of resection of hippocampus, whether or not the patient have radiotherapy. In addition, long survival is generally difficult in case of GBM or high-grade glioma. Taking these together, it is difficult to follow up long-term effects on memory function of tumor resection in this area. In summary, I think there are quite big difference between epilepsy and tumor surgery in this area. In brain tumors, hippocampus is usually enlarged, and moreover, the normal structure major temporal are frequently missed. And the pia mater of a major temporal lobe is sometimes damaged, and the PCL midbrain may suddenly show up during the survival resection. And for tumor located in ankles and hippocampal heads, the anterior approach can be good option to preserve visual field. I think that's it, and thank you very much for your attention.
Thank you very much, Professor. That was an indeed excellent presentation. May I request Professor Atul Goyal to make some comments about Professor Shunsuke Nakai's presentation. Professor Atul Goyal.
That was a absolutely wonderful presentation. See the inferior temporal horn, the location of amygdala, location of hippocampus, location of various structures in that region are so important. Location of choroid fissure, location of fornix, and of course, location of white fibers, as we have heard, location of the optic pathways, how the white fiber of the optic pathways go over the temporal horn and go behind. And he has shown how to approach from the front. So these are very important tricks when you are operating on the temporal horn, in the inferior temporal horn. And there are many areas, because inferior temporal horn and medial temporal structures are unique, because the development of that area is not only neocortex, paleocortex, archicortex, so all three types of cortices are mixed in that area. That is why that area is more prone for convulsions and epilepsy. So epilepsy is the issue. Medial temporal tumors are more often of benign, less aggressive character. Even the gliomas located in the medial temporal horn are quite low-grade tumors. So we have to learn anatomy of that area. It is not a regular anatomy. We have to learn in cadaver dissection. We have to go in the lab and see the dissection, open the temporal horn, see the choroidal fissure, see the choroidal point, see the dentate gyrus, see the fornices, see the hippocampus, see the amygdala. So all this anatomy has to be understood in a three-dimensional perspective if we are going to operate on this area. So I am very happy to hear this presentation. It is of course important for epilepsy surgery, there is no question. but it is important for so many tumors in that area, as we have seen. And this anatomy has to be learned by every young neurosurgeon, and nobody can learn this anatomy without going to the cadaver lab. Do you agree with me?
Yes, I think so. Thank you very much.
Thank you. Thank you for your beautiful presentation. My best wishes to you.
Thank you so much.
Thank you. Thank you, Professor Atul Goyal. May I request Professor Alexander Wozniak to make some comment with Professor.
Professor Nakaya, thank you very much. My congratulations. A great presentation, very nice cases, nice observation of everything. I have some comments from my experience about this surgery. So it's really challenging. This surgery is really challenging surgery. And first of all, I'd like to say that principles of skull-based surgery are very useful for surgery of the temporal region. And I use it every day. Usually we start with a meticulous investigation of the patients. First of all, the functional MRI, the memory, EEG. Then this surgery is impossible without intraoperative monitoring. Awake anesthesia especially for right-handed patients. And in practice, we have not so many cases of the clear hypocampal tumors. Usually they extend to the insula, and we must think about the strategy how we will approach this tumor and remove the tumor from the insula. It's more difficult, it's more sophisticated, more difficult surgery. And I have some questions for you, Professor. So this question for me really interesting for me because I have not answer from my practice. So can you predict or prevent the memory loss in patients with left hypocampal lesions? So in my practice, I had not so many cases like this. Actually, I had during the last maybe 15 years, I have only one case, one woman with a severe amnesia. It's only one with me, but I cannot predict. And another question, maybe more difficult question. When you remove the tumor of the hippocampus, you perform the epilepsy surgery usually. So do you extend this surgery to epilepsy or you limit your surgery only by tumor removal? Or just do you recommend to extend it to maybe hypocampal resection, to resection of the posterior part of the hippocampus? So do you think about epilepsy surgery during tumor removal? This is my second question.
Thank you very much your question. And about first question, you are talking about postoperative memory function.
Yes. Yes.
In my experience, about tumor in the dominant case, usually a little bit decreased after the surgery. And if the seizure is stopped, it gradually increased. So I think almost same before surgery. I checked 2 years, but after 2 years, almost same level in the dominant case. But in non-dominant case, usually memory function is not decreased preoperatively. But in some cases, memory function is decreased. In such case, if seizure is stopped, memory function is improved. I think in my cases.
Okay, thank you.
Thank you very much, Professor. You can see Kawase Sensei has hand raised. Kawase Sensei.
In a case, I'm speaking. In a case, the tumor extended more posteriorly, I recommend subtemporal root, but not the subdural temporal, but the epidural temporal approach, combined with zygomatic osteotomy. So in such an approach, no injury to the temporal bridging veins. So no retraction damage to the temporal lobe. And by that approach, it is not necessary to resect the hippocampus. So the brain damage may be minimal. So please try for the tumors extended more posteriorly.
Thank you very much. I will try. Thank you.
Dr. Dragon has a hand raised. Dr. Dragon, can you introduce yourself and ask question?
Hi, I wish you all wishes for Christmas and Happy New Year. And today all lecture are very motivated for young residents and for young neurosurgeons. I have just one question about 5-ALA fluorescent you use for glioma surgery just for high-grade glioma or also in low-grade glioma 5-ALA fluorescence.
Thank you for your question. We usually use 5-ALA for cases we think this is case is high-grade glioma. So we don't use it for the low-grade glioma cases.
Okay, thank you very much for answering.
Thank you very much. Dr. Abhidasha, you there? You can make some comments. Glioma surgery is one of your forte. So maybe in this region, glioma surgery around the major temporal lobe, your comments, please.
So Dr. Nakai, that was a very wonderful presentation and congratulations for your work. I have a couple of suggestions. So when you study the anatomy of the optic radiation, basically the Mayer's loop is the one that you have to avoid. So the Mayer's loop will come in the roof of the temporal horn anteriorly, and then more posteriorly, it is in the lateral part of the horn. So if you want to avoid a visual field deficit, you can go subcortical. So this approach to medial temporal tumors was described by Professor Goel in 1990s. And then we studied the white fiber correlates of this approach. So we've recently published that in World Neurosurgery. So there is a small area in the anterior part of the temporal horn where there are no fibers. There is nothing. So you enter the temporal horn in that part and you identify the hippocampus, the choroid fissure and the choroid plexus. And then you keep your dissection below that point, you will avoid visual field deficit. Also, you will avoid damage to the IFOF, which is above that, which is above the Mayer's loop, and it is running in the sagittal stratum. So you will avoid any paraphasia also in those, and you use that approach. Of course, the trans-Sylvian approach is also a good approach, but in our opinion, we found that the risk of injury to the uncinate fasciculus and to some fibers of the anterior commissure was greater with the trans-Sylvian approach. So we are routinely using this the cortical approach to the middle temporal gyrus, even for epilepsy and for mesial tumors, mesial temporal lobe tumors. But that was a great presentation, Professor Nakai.
Thank you very much for your suggestion. I will read the paper.
Thank you very much, Professor and Dr. Abhidasha for active participation and making the points. Any other questions from the panelists? Dr. Dilshad, are you there? Dr. Dilshad?
Oh, hello. Yes, I'm here.
Hi. Yes,
hello,
please go ahead and
everybody.
ask your question.
Merry Christmas. Thank you so much for your presentation. Actually, I'm also very interested in glioma surgery for the dominant hemispheres and left temporal lobe. And we've been using intra-arterial chemotherapy for the remnants of glioma surgery. What you have, if we have a residual tumor, we've been using this kind of technique for eliminating as a conservative treatment for glioma, mostly using Avastin and such other things from the chemotherapy. What is your opinion about this?
Thank you very much for your question. It depends on histology, I think. So usually in high-grade glioma, we usually do the radiotherapy and temozolomide and Avastin, bevacizumab. But in a lower-grade glioma, it's very difficult. It depends on case. Is that the answer for your question?
Do you use intra-arterial?
I've never. I don't have any experience of intra-arterial chemotherapy.
Okay. Thank you.
Thank you.
Thank you. Thank you very much, Dr. Dilshad. Are there any other questions from the panelists or from any of the attendees? Okay. So before I make the final announcement, I would request Professor Yoko Kato to say a few words about the conclusion of today's interesting webinar. Professor Yoko Kato Sensei. You are muted, Professor.
Oh, thank you very much, all the three speakers, especially Professor Kawase, and also the Rakuya Tanikawa, and also the Nakae. Nakae is my junior, and recently he studied a lot, and his lecture was excellent. Thank you very much. I think as ACNS, maybe in next year, we have more collaboration with some society. And I think the new year maybe will bring the peace, real peace, and the health, and the feel of the satisfaction to all of you, I think. And especially the Ukraine and also the Afghanistan, I think the may peace come really soon. We had a very nice Christmas, the YNS webinar today. Thank you very much.
Thank you very much. Anybody wants to say any closing message? Professor Atul, go ahead, or Kawase Sensei.
Kawase Sensei is talking something. Kawase Sensei, 聞こえません?
You are muted, Professor.
Dr. Yoko always hear this congress, so I hope she can chair this congress to grow and give a lot of knowledge to the young.
Sensei, thank you very much. So we will invite you the many times in the future. Okay? ありがとうございました。
So thank you very much, everybody, for participating today. I have two announcements to make. So first of all, to conclude this year as a ACNS YNS webinar series, we had a fantastic year wherein this webinar was only the workhorse of our educational activities, because in the beginning of the year, we still had some COVID going on. In the middle of the year, we had almost all the countries who had opened up for the international transit. And at the end of the year, again, we have some news coming out that some countries slowly started coming up with the COVID infection. So let's plan the next year. Next year, I think we will continue to have this ACNS YNS webinar series on every second and fourth Sunday, with the exception of only month of January, as our main workhorse of the educational activities. But with that, we'll try to conduct a few hands-on activities for the young neurosurgeon. And one of the such hands-on activity will be first in Bangladesh from 3rd to 6th of March. there'll be hands-on activities, especially for the young neurosurgeons in Bangladesh. One thing, and second thing, I think somewhere in the month of June or July, we will have our second World Young Neurosurgeon Congress, which will be held in Indonesia. We'll be finalizing the dates soon. So for those people for whom it'll be comfortable to travel, please do travel. And it's very important for the young neurosurgeon, as Professor Rokuya Tanikawa said, that he has at least 30 times visited different cadaver workshops. So we must do that or more in order to gain that much of experience. So webinar definitely is very good. You should learn the concept, but hands-on activities are again much important. The second announcement for the next webinar, as I said, that we conduct it every second and third Sunday, but we'll take an exception because the next month, that is January, is starting on 1st, and 1st is the first Sunday. So we'll take an exception. We'll not have it on 2nd and 4th Sunday. We'll have it on 3rd and 5th Sunday. That is on 15th and 29th. So 15th of January, we'll have our next webinar, same time with some interesting faculties. So everyone have a Merry Christmas, Happy New Year. Plan and strategize your new year well for the young neurosurgeon. Thank you very much. Anybody wants to say anything? Yes, Arion, please go ahead.
Oh, no, I was just waving to say Merry Christmas and Happy Holidays. No. Thank you to you all.
Wonderful to hear you.
Happy New Year to all of you.
Thank you. So Alexander, still we are waiting your student to come to our place. Anytime.
Yes, thank you.
Yeah,
I thought, yes, I sent you a letter. It's not so easy sometimes, but
I know,
because we have no consular in Kiev.
Yes.
Doctors must go to Warsaw. It's close, the nearest place. But I work on this. Yes, I will go on working.
Thank you so much.
And thank you. Thank you.
Wishes. Happy New Year. Bye bye.
Happy New Year and Merry Christmas. Bye bye.
All the best.
Bye.
Bye. Thank you. Thank you very
Merry
much.
Christmas.
Bye bye.
Bye bye.
Bye. Bye again.
メリークリスマス。
中井先生、ありがとう。